Practice. For the first presentation, may I invite Professor Thomas Justin Clark, Consultant Gynecologist, Honorary Professor of Gynecology, University of Birmingham. Warm welcome to you. And moving on to the topic, uterine septum in infertility, should we remove them? Let's begin.
Thank you very much, and thank you for those three video presentations. I thought they were wonderful. A really nice start to the day. So I'm going to speak to you on uterine septums in infertility and hopefully answer the question, should we remove them? Actually, before we start, can we have a show of hands? If you see a uterine septum in a patient with some history of infertility or recurrent miscarriage, could you put your hand up if you would remove them? Yeah, don't be shy. So there's a few. There's one at the back. Yeah, you can put your hand up. Yeah. So I would say, I'm going to take you two as a yes, yes, yes. So probably around a third of you. That's interesting. If you ask that question, I suppose it depends on the audience. But I was at a conference in Barcelona 2 weeks ago. It was a hysteroscopy conference. But if I'd asked that question to the Europeans, I think almost everyone's hand would go up. So in India, I'm obviously Indian. I'm a little bit more skeptical, but I'll come on to that. Basically, with septums, it's the most common congenital anomaly. Often prevalence studies vary. Depends on the population that you study, how you define a septum. But we know it's the most common one, and maybe up to 15%, depending on how you define it. And we know that the septum appears to be associated with adverse reproductive function, so increased risk of miscarriage, of preterm delivery, and malpresentation. Fertility actually is a little bit more contentious. The data of the association between fertility issues is less clear. This is a book that I edited. I can just plug that. I can recommend this book very highly. And we've sort of, a number of the images are taken from this book. But we can diagnose a septum in a number of ways, but often most of us will diagnose them a combination of ultrasound scan and hysteroscopy. But you can use MRI and hysterosalpingogram. And increasingly now we're using 3D imaging on ultrasound to better look at the shape of these congenital anomalies. Again, I was referring back to this hysteroscopy, the Global Congress of Hysteroscopy in Barcelona 2 weeks ago. There was a debate about classification. So we briefly touched on classification of endometriosis yesterday. But congenital uterine anomalies or Müllerian anomalies are no different. You can find a few different classifications, and you have to choose the one that you like best. But it would be nice if we had one uniform classification so we were all speaking the same language. But this is probably the latest classification. This is the ESRA/ESG, that's a European Society for Gynecological Endoscopy classification of Müllerian anomalies. And they classify a septum as their category 2, U2, uterine 2, and they classify it into A or B, A being a subseptate, so a partial septum, and B being a complete septum. And they define the actual septum itself, not by its size, but actually by the degree of the proportion of the uterine wall that actually dips into indents the cavity. So if it's more than 50% of the thickness of the uterine fundal wall, that indentation, then they consider that a septum. And they distinguish that from the bicornuate uterus by having a normal outline, or the external cleft is less than 50, the dip is less than 50% at the top. So that's how the ESG classification is. Probably the one that's been more established and has been updated recently is the ASRM classification. And rather than using a proportion of the fundal uterine wall as their way to classify a septum, they actually stipulate a specific length, so that is 1 centimetre, and they specify that the angle should be here it should be less than 90 degrees. If it's wider than 90 degrees, then they consider that an arcuate uterus. So what we've found with those differences in classifications is that you tend to get more septums detected using the ESG classification because the actual uterine wall itself can vary depending on where you take the measurement. So if you take it here or here, it was wider. Here and here, it's the same patient, it was smaller. And so as a proportion, the indentation, which is the same, 0.61, the proportion becomes greater than 50%. In this image, and in this image, less than 50%. So there's been some criticism of the ESG classification for this reason, but I'm not sure it's fully justified. There's pros and cons to either classification. But you just need to bear that in mind because a lot of the problems with studies I'll show you, a lot of the criticisms have arisen because people diagnose the septums some more liberally than others. And of course, if we're going to treat something, we need to be, detecting the same thing. So what's the biological basis for septums causing reproductive issues like recurrent miscarriage or infertility? So there is a variety of mechanisms listed here that are thought to play a key role. So on the one thing, epidemiologically, you can look at populations and say, oh, a group of women with septums compared to a group of women without have a worse reproductive outcome. So we can say that epidemiologically, that's an association, but causation is a slightly different thing, and understanding why that observation may be apparent is important. And these are the sort of basic science mechanisms. Is it related to how the hormone receptors are expressed? Is it related to problems with vascularization and certain endometrial growth factors? Is it simply related to the actual uterine muscle itself and contractility? We don't fully know, but these are the theories that have been suggested. So, should we remove them then? We can see these things, they seem to be associated with worse reproductive outcome. Okay, we don't quite know why, but we've got a few theories. So should we remove them? Well, I suppose the question for that is maybe we should if we can demonstrate a benefit. So the reason removal over the years has become more popular is because with the advent of hysteroscopy, and particularly hysteroscopic technologies, it's become less invasive, avoiding uterine incisions, so the traditional laparotomic metroplasties that are described in ancient textbooks. Now we can replace this with less invasive hysteroscopic removal. But we should be careful because just because something's more feasible, again, doesn't mean we should still be doing it because we can still cause harm. You know, hysteroscopy is not without potential risks. So if we are going to remove them, we've got electrosurgical approaches or we've got mechanical cold steel approaches, and there's a little bit of debates about which is the best way of doing this. Certainly, I suppose the comment around electrosurgical removal, some people feel that any sort of thermal artifact should be avoided in the uterus when you're operating for fertility reasons. But on the other hand, electrosurgical cutting is really very efficient. And actually, because these electrodes, so these two videos show miniature electrodes. This is a spring tip electrode on the left, and the other one on the right is the twizzle tip. But because the current density is so high, because they're such small electrodes, they essentially cut like a knife. And if you go back in and look afterwards, a few weeks later, at hysteroscopy, you often will see no residual thermal artifact, and you'll see the area completely re-epithelialized. But these videos show, I say, cutting away the septum on the left, and on the right is a video showing removal of a vaginal septum, and again, there's also an intrauterine septum as well as a double cervix there. So that's one way of going about things. So wait for transition. All right, I'll just wait for that to start whirring over. So I've got another video, hopefully it'll move in a second. I've broken the computer. So you can't even show the septum being removed. That's why we shouldn't remove them. Yes, just go down, I'll show you. Next slide, does this one go to this one? Yeah, perfect. Okay, fingers crossed, this slide's got 4 videos on the same one, but let's go for it. Keep going. This one, that's it, yeah. Okay, thank you. So again, this is a nice bit of kit. This is a miniature bipolar electrode. There's a resectoscope on the top right and the Collins knife on the left, and you can use either technique. On the top right, this is showing sometimes when you remove a septum, it usually pings away, sort of like knicker elastic, pings away, but sometimes you end up with a ridge of tissue, and so you can use a miniature electrode here to take away that ridge of tissue, so you don't end up with any ridges. And then at the end of the septum, at the end of the procedure, you can take a look. The key thing is you can see, just to look at it, you can see as you cut into through the fibroelastic septum, you'll start to see that pink appearance. That pink appearance is the underlying myometrium. And so as you start to see that, you start to need to be cautious because you are getting into myometrium. And if you start to see deeper myometrial blood vessels, and you want to try and approximate the level of cutting to almost where the uterine cornea and the tubal ostia are, maybe a little bit proximal to that. But there are a number of techniques, so you can see that that's a straightforward way of doing it. The other thing I would say it's important is we do a lot of what's called outpatient or office hysteroscopy with miniature scopes. So the advantage of this is patients don't need to fast. It's done outside of the OR. They literally come in, put their coffee down, hop up on the couch, have a quick hysteroscopy, and that's that. But what you can do in the outpatient setting is minor hysteroscopic procedures. And you can see here, that's post a resection. So you can see there's a residual, at 6 weeks, a residual sort of small defect. And actually, you do see that more commonly than you think. And so in the outpatient, you can just use some 5 French mechanical scissors and cut that away. So I think following up after adhesiolysis or after septum removal can be quite important. And 3D imaging, it's not essential, but it can reassure you that you've done a good job, that you've actually removed the septum. That's really the technique itself. So it's a nice technique. But as I say, even though it's a nice technique, we'll come on to some evidence now of whether we should be doing it. You know, there is a potential risk, particularly with electrosurgery, of complications. So we need to be confident that we're doing patients a benefit and not either just wasting their time and wasting resources, or even worse, doing them a harm. So what is the evidence for removal then? So we've seen the techniques and we've seen some background about prevalence and about potential etiology. But what about removing them? So I was asked to participate in a debate in the Netherlands at the end of last year about this. So I've taken a couple of slides that I created for that presentation. But as I say, to recap, we generally think septum is associated with outcomes, but we should only remove them if actually we improve prognosis by doing that. So I don't know if you recognize this chap. This is Professor Jacques Donnet, who's a huge icon in all things, particularly laparoscopic surgery, but endoscopic surgery. And so I had to debate against him, which was quite intimidating. And he, particularly being European, was very keen on removing septums. And so what I said in the talk was, well, you know, why are we doing it? Are we just doing it because it's fun? You know, what's the point? And the only point will be if we can improve fertility and prevent miscarriage. But, and you can tell I've showed you this slide yesterday, the elephant in the room is that whilst we can do this, you know, we're searching for evidence to show that it's beneficial. Now, this study from 2000, so I was a junior doctor like many of you at this point, was the reason that people got very excited about, you know, we should be removing them, because these observational studies, so these are what's called before and after studies, so they removed the septum and then they just collected, you know, clinical pregnancy rate, live birth rate, and they found, like, you can't really see this, but a huge effect. So they found that, I don't know, what was it, number of, so like 3%, is that right? Yeah, 3% term deliveries, live birth rate before, but afterwards 80%. There's very few interventions in medicine that will give you such a huge magnitude of difference. And it's implausible. So this is because if we'd left a lot of these women alone, if we'd randomized them, a lot of them probably would have had a successful pregnancy. I'm not saying as many as those that had the septum removed, but this illustrates why randomized studies are so important. You have to remove what's called selection bias. You have to know what the placebo effect is. So here, people said, oh, no, this is great. So people who liked septum said, we should be removing them. But they weren't really paying attention to the methodological deficiencies of this and over-interpreting the findings. So this in itself doesn't show, it's certainly not a negative finding, but it doesn't show actually that it's the right thing to do. But in any case, and I've discussed some of the biases in this study, in any case, people chose to ignore that and said, oh, no, that we should just go ahead. But that meta-analysis of observational studies, as I say, has some significant flaws. That was from 2000. Now, up until 2021, we had no randomized control trials. And so, as I say, the advocates were saying, oh, well, you know, the data we have, we should just be removing them. So there have been more recently 3 systematic reviews in different journals looking essentially at the same thing. Now, this is too small to see, and I've only chosen one outcome here, but it's probably the most important outcome, which is live birth rate. And if you look really just at the actual forest plots, this is the line. This line essentially is no difference. You know, if it's this side, it favours removing the septums. You get a higher live birth rate. If it's this line, it shows it's not beneficial at all. And you can see that the lines are all crossing the line of no difference. Apart from this trial, actually shows a very marginal benefit. But this is probably the worst quality review in that they excluded studies they didn't like. But they certainly excluded some studies. So what we can say from these meta-analyses is that these are controlled studies, not randomized, but controlled studies where they had a group with and without removing septums. It's shown no real clear, consistent difference. So my group with the Dutch produced a large multi-center retrospective cohort where we looked at women who'd, again, not been randomized, but just been had the septum removed or for whatever reason hadn't over a period of time. We identified over 250 women. And what we found is that during the time, the live birth rate was similar, 53% in the group with septum removal, 71% in women where we didn't remove them. And that wasn't, because the numbers were relatively small, that wasn't a significant difference, but you can see that they're comparable, and if anything, it seems to be favouring leaving them alone. Now, this caused absolute mayhem in Europe. I told you the Europeans love removing. The European Society of Gynaecology, when we published this paper in Human Reprod, loads of letters came in. Oh, how can they say this thing? And the study's awful. And oh my God, it opened up a lot of... they're all my friends, by the way, so it was a difficult few months for me. But to be fair to them, there are significant methodological issues, but it's as good a data as we have, and people need to be aware that we don't know the answer. Now, what made them even more angry was that we then published a randomized trial that had been running for several years. It was a very small trial, but it's the only randomized trial comparing removal of septums with not. And I'll go over my time, so I'll be quick. But basically, it showed no difference. We found that during the course of the study, we followed up to a year. The live birth rate was around 31% in the group who had the septum removed and 35% in the group that didn't. There was no difference between them. And you can see that the cumulative pregnancy, people criticized it, oh yes, but they had to wait for the septum resection section, and that's why the live birth weight was low, was no different, because they were waiting. But they misunderstood. We followed up for long enough, for a year after the septum was removed, and you can see in both groups, this is the grey is the septum removal group, it catches up. Even though there's a lag period because they're waiting for the septum resection, the actual cumulative rate of pregnancy is the same. So, and there's no difference in any of the other parameters here. They're all the same. So, a small study, but even so, and again, lots of letters, lots of criticism. Yes, there were criticisms. The main one being that the septums in this study were all small. There were only 2 complete septums out of 80. Most of them are quite small, and I showed you at the beginning there's a little bit of variation about diagnosis. But even so, that is the best evidence we have. So what does that mean for us? Well, it means really to conclude there's a community of hysteroscopists. So even my adversaries who are critical of the studies, we should at least now all agree that we need to do a big multi-centre international study where we can all, to actually identify, to address any criticisms and understand better. But what the trial has shown for sure is there is doubt about removing the uterine septums. So the ESRI guidance from 2016 is correct. We should only be removing septums in the context of surgical trials. We shouldn't be doing them in routine clinical practice. And I would agree with that. If we are going to design a trial, what should it look like? Well, we designed that small trial of 80 based on quite a large magnitude of difference in terms of, and the reason we based that was because I showed you that original meta-analysis that showed a 3% to an 80% improvement. So we powered it on 35% difference, which is a massive difference, and that gives you a small sample size. So most of us would probably accept 5%, 10% improvement is a viable improvement for our patients for a relatively non-invasive procedure. So we need to design a bigger study with a smaller powered to detect a smaller difference. And I think we need to probably all maybe include just complete septums, even though they're less common, because we can all agree that that's a septum. With a partial septum, there may be some, oh, is it septum, is it not? So a more diseased population of women with a complete septum, with a reproductive history of infertility or recurrent miscarriage, and a big trial. So that's what we need to do. And we need to all get a big group together. And if we can do that, we can hopefully answer the question. Whether we'll ever do it, I don't know, but that's what we need to do. Final slide, from a clinical point of view, though, what does this mean? So I do think the academic in me says you should only remove septums within a research trial. But at the moment, there's no research trial I'm aware of going ahead. So what we can say to our patients is, if they've got an incomplete septum, we need to explain to them there's very little evidence of benefit. And unless, for my practice, they've got a very significant history, not just like 1 or 2 miscarriages, but 4, 5, 6 recurrent miscarriages, then I'm not going to remove that septum. If they decide that if they've got a complete septum, I'm still, with an adverse history, I'm still going to remove those because the trials I show you didn't really address those. But if a patient, and often these women are desperate, absolutely wants that septum removed, then I would still do that for them as long as they're fully aware of the potential of limited benefit or no benefit at all. So I'm not saying absolutely don't do it, but do, particularly for your partial septums, particularly with not a very strong history of reproductive failure, I would be very cautious of jumping in routinely to remove the septums. Okay, so thanks to some of my colleagues for lending me some of their slides, and thank you for your attention.
Well, thank you so much, Professor Thomas Jessin Clark, for the beautiful presentation.